Good evening. Welcome to this Ask the Expert event focused on colorectal cancer. Tonight, in honor of Colorectal Cancer Awareness Month, a panel of experts will share crucial information about prevention, early detection, and support for those diagnosed. We will also answer your questions live. To submit a question for our panel, simply drop it in the chat here on Facebook. Let's meet our panelists. First, we have Dr. Baldwin Young, a board-certified surgeon with special training in colorectal surgery. Dr. Baldwin Young is joining us today from Mary Washington General Surgery. Next, we have Dr. Bradford. Dr. Bradford is a fellowship-trained colon and rectal surgeon, adept in open, laparoscopic, and robotic surgical techniques, who is also joining us from Mary Washington General Surgery. In addition, we're pleased to welcome Dr. Durrell, a board-certified and fellowship-trained gastroenterologist with Mary Washington Gastroenterology, which, fun fact, reopened today as part of the Mary Washington Healthcare family. Dr. Durrell is also a fellow of the American College of Gastroenterology. Welcome, panelists, and thanks for joining us this evening. Dr. Baldwin Young, I'd like for you to start the program. So let's just dive right back into the big questions. What is colorectal cancer, and why is it important to raise awareness during March for Colorectal Awareness Month?
Thank you, Addie. So normally cells in our body cannot grow uncontrollably, but with cancer, that's exactly what happens. The things in our body that tells our cells to stop growing, stop working. And then cells can grow uncontrollably and even spread to other places in the body. So when this process starts in the large intestine, also known as the colon and rectum, it's colorectal cancer. So colorectal cancer is really important because it is the third leading cause of cancer in the United States, and it's the second most common cancer that causes deaths in America. And what's really interesting is that a lot of colorectal cancers to some degree are preventable. So if only 2 out of every 3 people who are diagnosed with colorectal cancer, I'm going to say that again because that's a big number, 2 out of every 3 people who are diagnosed with colorectal cancer, who die from colorectal cancer rather, their deaths could have been prevented if only they had had proper screening, which Dr. Durrell is going to discuss a little bit later, I believe. And so the point of discussing colorectal cancer during March, during Colorectal Cancer Awareness Month, is to make sure people are aware of these statistics, and also to make sure people are aware of early signs of cancer and what to do about those signs if they develop any, and also to know when to get screened. And even if we can't prevent colon and rectal cancer, if someone gets a colonoscopy on time, we can potentially diagnose colorectal cancer early. And when we do that, it's easier to treat the disease. There's a higher chance that we can cure the disease. But yet, in people ages 45 to 49, unfortunately, only 1 out of 5 people are getting screened on time. So this is a very important month. And I'm really appreciative of Mary Washington hosting this event so that way more people can learn about this.
Thank you, Dr. Baldwin Young. Yeah, I know that the word colonoscopy, just in general, that's usually goes hand in hand with procrastination. Like, I'll do that later. And so we will actually get to talking about colonoscopies later, but we will talk about it. Dr. Bradford, can you tell us more about the risk factors for colorectal cancer and early signs to watch out for?
Sure, I'd be happy to. So first off, thank you, Dr. Bowen Young, for that introduction. So a lot of conditions of the colon, including colon and rectal cancer, have some risk factors. And unfortunately, a lot of them are just ones that we simply have by being in America and living an American lifestyle and eating American food that we like. Things that are linked also to diverticulitis and diverticulosis, which are little pockets in the colon, are also linked to colon cancer. So for example, a sedentary lifestyle, meaning, one that lacks exercise. A diet low in fiber is linked to colon problems and colon cancer. A diet high in alcohol, a diet or smoking tobacco products, those are also linked to colon rectal problems. High red meat consumption is also linked to colon rectal problems. One of the biggest risk factors for colon cancer, however, is simply genetics. So a lot of people have colon or rectal cancer in their families, or precancerous polyps or adenomatous polyps in their family members. those folks are generally at higher risk, and sometimes we start screening them even earlier than the standard recommendation, which is now 45 for the last several years. Things to look out for. I mean, if you already know you have a relative, a first degree relative like a mom or dad who has a history of colon cancer or colon polyps, it's probably important to ask your physician if you qualify or you're early enough to have your colonoscopy. However, we would always offer a colonoscopy for any symptoms that could be indicative of a colon or rectal cancer or problem. So those would be an unintentional change in weight. So for example, if you've been losing a lot of weight and there's not really an explanation for it and you haven't been trying to lose weight, that's a concerning finding that could be indicative of a cancer. Changes in folks' bowel movement. So if people normally had one type of bowel movement their whole life, and then over the past 6 months, 9 months, 1 year, several years even, it's changed significantly. That's another indication that we'd want to know about to get a colonoscopy or evaluate for colon problems. Any kind of blood in the stool is always something concerning. So if there's ever blood in the stool, we'd recommend speaking to your a medical professional about this. Blood in the stool can be, from benign things, meaning non-cancerous things, but it can also be from something more concerning like a colon cancer. And any sort of blood in the stool would be concerning. So that's the whole spectrum of it, bright red to maroon to even black can be concerning for some sort of bleed in the gastrointestinal system. Those are the main thing. I think those are really the main things that we should touch on. But really, any kind of significant change in your health and your bowel movements should prompt talking to a medical professional.
That's wonderful to know. Thank you, Dr. Bradford.
You're welcome.
Dr. Durrell, okay, let's start to talk about screening a little bit. What role do screenings play in colorectal cancer, and what should our viewers keep in mind about these tests?
Well, first of all, thank you so much for having me today. It's what a timely discussion, because as we already said, March is a colorectal cancer awareness month. And as Dr. Young mentioned, is one of the top 3 cancers and top 2 when it comes to death. And the special thing about colorectal cancer is it's a preventable cancer. It's preventable. If you do the screening properly, we can prevent most of it, So that's why the screening becomes very important. Yeah, so for most of the cancers, if you look into like breast cancer, cervical cancer, other cancers, so the screening tests are designed for early detection, right? You detect early so that you have a better treatment. In colorectal cancer, you actually can go one step before that. You can actually detect the precancerous lesions like polyps, that's what we call. So you can actually prevent it by using the screening test in time, in the right manner. You can actually prevent it, not only just early detection, you actually can prevent it. So that's why the screening is so important for colon cancer. And fortunately, we have different types of screening tests available, but at the same time, they have also pluses and minuses. And if you allow me a little bit more time, I can go over a little bit detail on that. You want me to go a little bit more on that?
Yes, please.
Yes.
We're going to get
most common, the gold standard for colon cancer screening is colonoscopy, which is putting a scope with a camera from the rectum and looking into the colon directly. Like we visualize the colon directly with the help of a light source and a camera and take a good look. That's the gold standard. That's the ultimate test for colon cancer screening as well as for diagnosis. Like as Dr. Bradford just mentioned, that sometimes you are not only completely symptom free, but if you have lots of symptoms like you have bleedings, any kinds of rectal bleeding, blood in the stools, change of your bowel habits, or having weight loss and symptoms like abdominal pain, things like that, then again, we call that diagnostic. So even that, what we do is a colonoscopy. When you are having no symptoms at all, now you're at the edge of screening, which is like 45 right now, 45 and above, 45 to 75, colonoscopy. That's the gold standard. But for people who have no symptoms, and they don't have any high-risk family history, what we call average risk people, there is alternate test to colonoscopy. So they could do a stool-based test, and sometimes there's even a new blood test coming now, and there is some imaging, like a virtual colonoscopy, they call like a CT colonography. So there's some alternates out there. But those are, again, we just have to use the keyword for people who are without high risk history. So those people are like people who did not have any family history of colon cancer or high risk colon polyps. They did not have any of those symptoms that we just mentioned, and they didn't have any other chronic conditions like IBD, like Crohn's or colitis, or other kind of like genetic polyposis syndrome. So if you have nothing like that, you're very average risk. So you have options like a stool test, where there are a couple of tests like that called FIT test. There is something called, you used to call something called a guaiac-based test, like a occult blood testing, FOBT, that used to be the one test. Second one is called a FIT test. And the third one right now is called Cologuard. So there's 3 different types of stool test. And then, of course, there's a colonoscopy. There's alternate is something called flex sigmoidoscopy, like there's a short scope. Instead of having an entire length of the colon checked, they just only checks the bottom half of the colon, like the rectum and the sigmoid and the left colon. So that is also available. And there is a virtual colonoscopy, which is also called CT colonography. So these are different options available, but they all have their positives and negatives, and which one to win. We can probably discuss further. Yeah, so these are the tests. And screening is right now, the American Cancer Society and all the other guidelines say you start at 45. 45 is the new 50. Used to be 50, but there has been data saying that like in the last 10 years, the colon cancer incidence in people 50 and above is actually decreasing, because we have this screening program already in place for almost like 20-30 years. So colon cancer every year, 1% decrease in people 50 and above. But then the data found that people who are between 45 and 50, under 50, annual incidence of colon cancer is increasing by the rate of like 2.5%. So younger people are at also increased risk. That's why they changed the age to 45, even for people without any history, any family history or other risk factors. Anybody who has a strong family history, they start at least by 40, or sometimes even younger than that. Okay.
That's wonderful. Thank you. Yes, listeners, if there's anything you take away from this, 45 is the new 50. Start looking at it a little earlier. And it sounds like there's a lot of new advancements and options in screening. So, Dr. Baldwin Young, can we talk about some advancements in colorectal cancer treatment? Are there any new, is there anything patients should know?
There's a lot patients should know. I would definitely reiterate, if you're having any symptoms whatsoever, please talk to your provider about it. If there's a question, a lot of people don't know their history of high risk polyps in their family. A lot of people don't talk about things. So one, what to know, talk about your family history. Talk about what grandma and grandpa had. Let your children know what you might have, because it will make a difference in their lives. In addition to all of the other symptoms that everyone said, I would add one more: a change in stool caliber. That means how skinny or wide is your stool. If your stool is very skinny, like a pencil, that could be concerning, especially if it continues. Once you talk to your doctors, we can talk about the full realm of various things that we can do. There are some surgeries that we do, a lot of surgeries that we do, and the type of surgery we do depends on where the cancer is located in the colon and rectum. A lot of people don't like talking to us surgeons because we might talk about a bag or a colostomy or ileostomy. That's the medical term for the bag that we give if we can't put people back into their normal anatomy. Trust me, you can ask Dr. Bradford. We try our best not to give people bags. No one wants a bag, but we have to do that sometimes depending on the type of cancer someone has and things that are specific to them. So aside from all of that, there's also chemotherapy, which are medications that can be used to treat colon and rectal cancer. The timing of when colon medical therapy is given, again, depends on the type of colon and rectal cancer, where it's located, how far along it is. Sometimes we can treat with radiation therapy, but there are some newer tests, therapies, particularly something called immunotherapy. So immunotherapy is a group of medications that can be used to target someone's immune system to then try to attack the cancer cells. A lot of times our immune system is not meant to attack our own cells. It's to attack things that invade our body, but somehow cancer doesn't get picked up by our immune system. So these medications are used to kind of switch something on or off in our immune system so our immune system can attack those cancer cells. There are various ways that we monitor cancer after cancer is treated as well, or during treatment. So one advancement is something called ctDNA, or circulating tumor DNA. So researchers have found that cancer cells have little DNA particles that travel through our blood. So if someone has colon and rectal cancer and their blood is checked, we might be able to detect this DNA. So when Dr. Bradford or I or another surgeon operates on someone, we like to check this number to see if it goes to zero. If it goes to zero, that's a really good sign that we've treated all of the cancer, but we might still recommend other treatments like medicines. So it's not completely certain how reliable this test is right now because it's relatively early in use. But over time, there's more and more research that can help guide us to know when we need to change our management based on this medication. One big thing at Mary Washington Healthcare is the use of robots in surgery. Robotic surgery has been around for a long time. I trained many years ago in a minimally invasive colorectal cancer, colorectal surgery fellowship. And even then we were training in robotic surgery, but specifically for Mary Washington, Mary Washington has put an investment in getting robots for both Stafford Hospital and Mary Washington Hospital. So altogether, we have 5 of the latest robotic Da Vinci robots, which are called the DV5 robots. And those are really important because robotic surgery has been shown to be associated with slightly less pain after surgery. And if you have less pain, that usually means you can get back to your usual activities a little bit faster than with some of our older techniques of doing surgery. And then also it's associated with a shorter hospital stay. Nobody likes being in the hospital. You can't really get much sleep in the hospital because nurses are in and out. So the faster we can get people home, the better. And there are some other benefits to robotic surgery as well, but it's been great having the DV5s at Mary Washington and Stafford Hospital to help our patients get better faster.
Yes, thank you so much, Dr. Baldwin-Young. I know at Mary Washington Healthcare, we are so proud of we call it our fleet of robots. We have the largest fleet in Northern Virginia. And if you get an opportunity to come and experience one of our robotics expos, you get to actually use the machine yourself and operate on a teddy bear and open candy bars. It's incredible. So I highly recommend that for all listeners. Dr. Bradford, we actually had a question from a listener. What is the time frame between screening for colorectal cancer? I had 2 normal colonoscopies. They were 5 years apart. Then I was informed that I didn't need to get another colonoscopy for 10 years. I am 8 years out from the last screening. Is 10 years still the norm, or should I think about getting come in to get screened sooner?
Just to clarify, I think I heard that the patient had previously had colonoscopies 5 years apart. And then since they had nothing, they recommended them go to 10.
Yes.
I think in order, I'm a little bit worried about offering just personalized medical advice on the channel. I don't want to lead anyone astray, but there was likely a reason that they had previously the 5-year plan. And before I, offer a full recommendation, I would just like to make sure I'd have to go through their history completely.
Nope, that's a great call. And whoever submitted this question, if you want to reach out to our webmaster email that we'll put in the chat, we'll see if we can get you some further information.
Yeah, if I may, I can also help a little bit there because we frequently have this kind of questions about when to do kind of thing. And we are generally the doctor who does the colonoscopy usually gives the recommendation when to repeat again. So what we do at that time, we look into your personal history, like what are your risk factors? We look into your family history. We look into the quality of the exam, whether this exam was perfectly clean, it was a complete exam, adequate view, no problem during procedures, like there was no spasms in the colon, all part of the colon was fully viewed. And then if you had polyps and not, so those factors are taken into account, okay? So that's why it is usually important to review your colonoscopy with a provider, and then, because some people with the same kind of like a findings may be given 5 years, but the other people with the fistula polyps could say, hey, maybe you can do in 7 years or 10 years, because there are different types of polyps. There's a size of the polyp matter, the number of the polyp matter, the histology, the biopsy results of the polyp matter, your family history matter, your quality of the exam matter, the reason it was done matter. So lots of things matter. So it's not all created equal. So that's why it is best to discuss is with the doctor who did your previous colonoscopy and what is my right recommendation. Like even if I do one of my colleagues colonoscopy, I usually tell them, hey, talk to your doctor. Like we have 11 doctors. Sometimes we do colonoscopy for one of my colleagues. I hesitate to give them the final recommendation. I'll say, look, looks normal to me, maybe good for 10 years, but double check with your doctor, review all those factors and put in the equation. That's what I will tell.
Thank you,
And
Dr. Oh, sorry, go ahead.
it's okay if I may add, this goes back to what I was saying earlier. Talk to your doctor. If there are symptoms that you're having, talk to your doctor. When it comes to the type of surgeries we do, and if other therapies are recommended, you have to talk to your doctor. You can't think that anyone's disease is the same as someone else's, because there are so many different details that we look at that help us to determine what's the right thing for each individual patient.
Yes, thank you to all three of you. This is why you guys are the experts. So, Dr. Bradford, going back a little bit too, if you need to have surgery as part of your treatment plan, what can patients expect for recovery times and outcomes?
That's a great question. I'd like to piggyback on what Dr. Baldwin-Young said earlier. So she had mentioned that robotic surgery and minimally invasive surgery, it's the main goal is to, make the recovery easier on patients. So, historically, and I mean currently, our main concern with treating patients is making sure that we're doing as surgeons, especially making sure we're doing an adequate operation. There's so much we do know about cancer, and there's also so much we don't know about cancer. And again, piggybacking on what she said, everyone's cancer is a little bit different. Sometimes they're treatable the same way, sometimes they're not. So with better advances, we've been able to kind of determine when we don't need to be quite as aggressive with certain things. So one of those is laparoscopic and robotic surgery. So it's essentially at this point, it's been studied ad nauseum, and the outcomes are going to be similar. There's not going to be any kind of worse cancer type outcomes with a minimally invasive operation in the hands of a well-trained surgeon with a traditional like big incision on the abdomen. So, our biggest goal is kind of essentially, the health of the patient and treating the cancer comes first. But at the same time, recovery is really important. Less time in the hospital is important too, because the less you're in the hospital, the earlier you're able to get up and move around, the less likely you are to get things like pneumonia, blood clots, all those things. So they all play a really big role. So if you look on what we advertise on our Mary Washington and Stafford robotics poster, is it says, ask your doctor or your surgeon if you are a candidate for robotic surgery. So I would say, the majority of people, depending on what operation, might be a candidate for a robotic surgery. And that's a very cool innovation in the past, 10, 15 years. It allows us to make even smaller incisions on the abdomen, and despite that, have even more dexterity when operating. So I would say generally a colon resection that was done on the robot that proceeds as planned. Patients can expect anywhere from 2 to 4 days in the hospital. On average, I would say, sometimes it's a little bit longer, sometimes it's a little bit less long. And we try to be realistic about, how long we're telling people to be in the hospital. Our recommendation for how long you're in the hospital and your recovery might be a little bit different depending on what type of surgery you had. But in general, I would summarize by saying this. So the vast majority of people, of my patients at least, basically maybe about 3 to 4 days in the hospital. Once they go home, I see them at generally 2 weeks postoperatively and 6 weeks postoperatively. At 2 weeks, I generally allow them to eat whatever diet they want. For the first 2 weeks, I generally have them on a low fiber diet, which is essentially the goal of that is to prevent a lot of roughage and like a big salad from going through this intestinal connection that we just made. Basically, at 2 weeks, that's essentially healed. Then for 6 weeks, generally people experience more fatigue than they previously did. But essentially at 6 weeks, people are basically back to normal. They don't really have any lifting restrictions anymore. And generally, if it's for a cancer operation, we will know the final pathology by about maximum 2 weeks. And we have a very robust, what's called a multidisciplinary tumor board here at Mary Washington Hospital, where we discuss newly diagnosed cancers. And it includes gastroenterologists, surgeons, oncologists, radiation oncologists, pathologists. Everyone comes up with the best recommendation for the patient based on the patient themselves and what the biology, the very specific factors of their tumor were. So in general, that's how I would summarize most of what you can expect from a colon surgery.
Thank you. That's incredible. And it's nice to know that, if you were to be diagnosed, your case is being looked at by a whole board of physicians who are helping to decide the best case of action.
Correct. Yes.
Yeah, that's amazing. Thank you. All right. So thank you, panelists. Now we're going to move into our Q&A session where we will answer some questions submitted by the audience. Let's see here. So Dr. Darrell, does a previous instance of a small bowel obstruction have any bearing on a future case of colorectal cancer?
Okay, so let me try to clarify. So colorectal cancer, we are talking about the cancer of the colon and the rectum. As you know, the gastrointestinal tract is a very long, like a tube. It's almost 20 feet. So it has an upper GI tract, like esophagus, stomach, the duodenum. Then there is a whole length of small bowel, which is almost like 10 feet. And then you have a colon. Colon is about 3 to 4 feet. So colorectal cancer usually is a cancer that happens in the colon, the large intestine, and in the rectum. So somebody has a small bowel obstruction, they may have other kind of cancer, like a small bowel cancer, or maybe some prior surgery that led to like adhesions, and that led to like a obstruction because of the scarring and the adhesions, so things like that. But sometimes a small bowel obstruction can also happen because somebody may have Crohn's disease of the small bowel. If somebody has a Crohn's, that is a high risk for colon cancer. Yes, any kind of abdominal issues like a surgical or obstruction, something like that. Sometimes, and again, sometimes the small bowel obstruction may be because of actually somebody had a colon cancer, and then the cancer had metastasized to the lymph nodes and other places, or maybe adhesion because the small bowel and the colon are actually packed together. Sometimes the cancer is so advanced that it might have actually spread to the small bowel and led to like a knot formation. So different kinds of obstruction happen. Yeah, those kind of symptoms would be considered alarm symptom, and definitely needs to be seen by the doctor, and then maybe get a right kind of imaging and first, and decide which is to focus. If his focus is in the colon, then they will send for a colonoscopy. If it is primarily a small bowel lesion, then that may require different kind of workup. Just having a small bowel obstruction alone is not considered very high risk for colon cancer, but some of the small bowel obstruction can be because of things like Crohn's or other things. So that's why this is also considered one of the alarm symptoms.
Okay, thank you so much. Dr. Baldwin-Young, this next question is for you. I'm having trouble convincing a loved one to go in for a colonoscopy. What advice do you have to encourage my family member to get screened?
I would recommend that that family member talk to other people who have had a colonoscopy so that it becomes more normal. And when you understand what someone else has gone through with a colonoscopy, most people will say, it wasn't that bad. The worst part of it was the day before the procedure, because you have to do something called a bowel prep, which is where you take pills or drink liquids to clean out your digestive tract. So when the physician goes in with a camera to look inside, it's nice and clean, and you can actually see the walls of the colon. The other thing I would advise is look online. There's the internet is not the best place for all information, but if you can't get someone to a doctor, that is something that could be done, where you can look at like AI videos, if you will, of colonoscopies, just to see what it's like. And number one advice is just get them to go to the doctor. Going to the doctor does not mean you are signing up for anything. It doesn't mean you're getting a colonoscopy. It doesn't mean you're going to have colon cancer. It doesn't mean that you're going to have surgery. Going to the doctor is just to have a conversation, just like we're having a conversation now. So you can learn about what risk factors you have. You can learn about some of the things that we're talking about here to understand the benefits of colon and of colorectal screening. So I think going to a physician that you trust, that can speak in terms that you understand, is going to be very, very helpful to try to encourage that person to do what's in their best interest.
I
Yeah.
love
And if you don't mind, can I also add some other things? Because yeah, exactly. So perfectly, thank you. So yes, let me give you give some data. For example, like as I said, colon cancer is a preventable cancer. 75% of the colon cancer that we are talking about scared to have I need to, whether I have to have a bag, whether I have a chemo, whether I have immunotherapy, 75%, 3 out of 4 people who we diagnose colon cancer never had a screening. Never had a screening. If somebody actually had a screening, their chance of having a colon cancer is just only like a 25%. So 3 out of 4 patients who we diagnose colon cancer never had a screening. So that's the thing. That's why screening is so important. But again, screening doesn't mean only colonoscopy. As we earlier said, there could be an alternate. So for example, you can talk to your primary doctor. This screening guidelines are available. The American Society of Gastroenterology, which I belong to, they have a guideline. American Cancer Society has a guideline. US Preventative Task Force has a guideline. Family physicians have a guideline. American Medical Association has a guideline. All society have a guideline. They all are available, and all primary care doctors are aware of the guidelines. So they will give you the right kind of screening. Not all screenings are colonoscopy. Yes, as we say, that could be if you are very low risk, you have no other family history, no symptoms, nothing, you might be okay to do the FIT test or maybe the Cologuard test also. Those alternates are also. So rather than doing nothing, doing something is so important, because the colon cancer, yeah, those FIT tests and the Cologuard are not great to detect polyp, which is preventable, but at least they will detect early colon cancer. There's like around 80%, 90% of the time they will, if you have a cancer, at least it will detect it early. So rather than doing nothing, do something. But if you really want to prevent it, colonoscopy is the best. But again, if you have lots of reasons not to do a colonoscopy, there is an alternate test also. So just don't shy away. And even colonoscopy is nothing. Like I do colonoscopy, 15 colonoscopy every day. We in our center, we do maybe 40 a day. We do like 10,000 colonoscopies every year. It's pretty safe. Pretty normal. Is the prep, like Dr. Young said, the day before, the prep may be what people talk about, but lots of improvements there. Nowadays, we have actually pill prep. You don't even have to drink those gallon of solutions. We have preps that are like you can do like a mixed with Miralax and Gatorade. You can make your own prep. So many different ways you can do it. So an anesthesia is great. It's pretty safe. Yep, colonoscopy is pretty safe, much better than the 10 years ago colonoscopies. Technologies are better. We even have high definition equipments. They are all sleek and very small. We even have AI assisted colonoscopies. All things are there. But again, sometimes you may not even need a colonoscopy. You could just do some alternate tests and it still be fine. So that's why don't just shy away. Talk to your primary care doctor. I wanted to emphasize that.
Yeah. And one of the fears I feel people have is the fear of going to sleep or feeling something during the procedure. So most people will choose to get anesthesia during the procedure. So most people don't remember anything from the procedure. They don't feel anything during the procedure. So that's important to know. And for people who are afraid of anesthesia, if you speak to your gastroenterologist, some people can have what's called awake colonoscopies, where anesthesia is not used, and gastroenterologists who do this every single day, or surgeons, can use certain techniques to decrease the symptoms that someone may feel during the colonoscopy if they choose to stay awake.
Yeah, that we have patients who have like, especially they are in high security clearance. Some people never want to go, and like FBI people, some yeah, they have requested without sedation. We do that also. I mean, there's so many options available, and plus it's so important to get it done. So that's why, and as I said, 3 out of 4 people who actually are diagnosed with colon cancer, they never got a screening. If they had a screening, that's how we feel. Because if they were up to date on screening, we could probably not deal with the colon cancer. Maybe we'll be dealing with like advanced polyps or something. Sometimes if you detect early, even like Dr. Bradford earlier mentioned, we have colon cancer, we diagnose, we present in that multidisciplinary tumor board. Dr. Young remembers I have presented cases like I do a colonoscopy, the patient had never had a colonoscopy, but I do it, now I find a polyp that looks pretty concerning, I remove it, and we find a cancer. But then I present in the tumor board and they say, look, it's all you are done. It's already done. So you removed it. There is a clear margin. It's a stage 1. Probably doesn't need anything more. Just monitor. So sometimes even early stage cancer can be just managed by a. So if you can detect early, you don't have to talk about those bags. You don't have to talk about big surgery, chemo, radiation. So important to go early. Prevent it. If possible, if you are a little bit late on prevention, don't shy away. Even if you are 10 years behind, get it done because you can detect early. And guess what? If you have a normal colonoscopy, great. Then your risk in the future is going to be really, really low.
Oh my goodness. Well, I'm not 45 yet, but I'm convinced. I'm sign me up. I'm ready. Okay, so we're actually at the end of our time here. So first, I would like to say thank you to Dr. Baldwin Young, Dr. Bradford, and Dr. Durrell for sharing your insights and your time and expertise with us tonight. Secondly, I'd like to just have another reminder announcement that Gastroenterology Associates of Fredericksburg, or GAF, joined Mary Washington Healthcare today and will be known going forward as Mary Washington Gastroenterology. The practices will remain at their current locations at 1031 Care Way in Fredericksburg and 125 Hospital Center Boulevard, Suite 309 in Stafford, just adjacent to Stafford Hospital. There's just some key takeaways that I know I picked up on from tonight, which is 45 is the new 50. Talk about it. If you have history, your parents have history, like make it a conversation. Let's normalize it and get screened. So with all that, I'm going to wrap this up and say a big thank you to all of our viewers for tuning in to this Ask the Expert event. And remember, Mary Washington Healthcare offers a range of resources for those diagnosed with colorectal cancer, including access to specialized care, screenings, and support services. So we invite you to visit us online to learn more at cancer.mwhc.com. And be sure to watch Mary Washington Healthcare Facebook page and our other social media channels to stay informed of the latest health and wellness information for our community. So stay safe, stay healthy, and have a great night. And get screened.